Good morning. Gonghei Fat Choi. Happy Chinese New Year's. My name is Lydia Santiago. I'm the clinical coordinator for KSARC, and I'm a member of the diversity committee here at UCSF. And I want to introduce William Martinez, Dr. William Martinez, who's an assistant clinical professor at UCSF and the director of child and adolescent services in the division of ICAP at San Francisco Zuckerberg General Hospital now. And his specialty is in children's mental health, Latino children mental health. Okay, so help me in welcoming Dr. Martinez.
Thank you, Dr. Santiago, for that introduction, and good morning, everyone. I'm excited to be here to be talking about some of the work that myself and my collaborators and colleagues have been working on since I started faculty here about 2 years ago, specifically focusing on school-based interventions for newcomer immigrant youth. To kind of give you a little bit of an overview today about what we're going to be talking about, I first want to kind of set the stage and talk about disparities generally among newcomer immigrant youth, and in particular youth from Central American countries. And then talk about why school-based prevention programming is kind of a front line, and review some recent systematic reviews on school-based prevention programming that is specifically targeting these newcomer immigrant and refugee populations. Throughout, you're going to hear me talk about community engagement and collaborative frameworks. A lot of this work would not be possible without these collaborative frameworks and with community participatory models that have been used in the development of this. And finally, I'll talk about Fuerte, which Fuerte means strength in Spanish. And this is the school-based prevention program that was developed in the Department of Psychiatry and then further refined and disseminated through the Department of Pediatrics at UCSF. And it's the program that we're all collaborating on right now, and I'll tell you a little bit more, as well as a randomized control trial that we're getting ready to start for it. But first, the story begins, and before I begin this story, I want to kind of set the stage with all the collaborators that are involved. There's a number of cast of characters that have been involved in the development, not only of our Fuerte program, but of this presentation itself and the various pieces throughout. So the story begins with Drs. Marisol Romero and Ryan Matlow. And I'll talk a little bit more about, how this all came about, but they were, when Fuerte started, they were postdoctoral fellows in the Child and Adolescent Services Clinic in the Multicultural Clinical Training Program. And they developed the initial part of Fuerte, and then 3 pediatric residents then took Fuerte and disseminated out throughout the schools in San Francisco Unified. And this is Drs. Peter Kuch, Hemino, and Holly Vo. And none of this work would be possible without our collaborators in the San Francisco Department of Public Health. And primarily, this would be Maximilian Roca, who's now the acting director of Children, Youth, and Families for the San Francisco County Department of Public Health, who started the Unaccompanied Minors Work Group a number of years ago, which is where a lot of this work has sprung about. And then Dr. Farah Faraman, who is now the Assistant Director of Children, Youth, and Families, and also was a postdoc fellow at the time this was initially developed at Child and Adolescent Services in the Multicultural Clinical Training Program. And I also want to mention the Director of Mission Family Center, which is a civil service clinic, Roban San Miguel, who has been instrumental in helping link providers at the county who are able to then disseminate this program in the school district. And in addition, Angie Romano, who is the district coordinator for the Refugee and Immigrant Services at the San Francisco Unified School District, she has been instrumental in helping bring this and creating the partnerships with the schools that were needed. And finally, and most importantly, I want to mention the youth and the families. The program was created for them, by them. Their input has been part of the development of this throughout the way, through focus groups, through semi-structured interviews that were held in the pilot phase and now formally will be held through the randomized trial. And informally, in many ways, they've provided a lot of input in what we've done and what we continue to do. So without them, this program would not be here. And first, I want to sort of set the context for why this work is important and why it's much needed. So currently there are about 3 million youth under the age of 18 in the United States who are considered immigrants, right? Are non-U.S. born. California is the top destination for these youth, with the Bay Area being the 5th in the nation for the most number of immigrant youth in the country. We're actually number 1 in terms of per capita youth. We have the largest concentration per capita of immigrants in all of the United States. And about a quarter of youth in the United States are either first generation, meaning they were born outside the U.S., or second generation, meaning they have at least one parent born outside the U.S. Right now in 2018, and that's important to note. So immigration is a salient construct for a quarter of the youth in our country right now, and that number is expected to rise in the next 20 years to about a third. So a third of youth in the United States by about 2040 are expected to either be born outside the U.S. or to have at least one parent born outside of the United States. And then to go back a couple of years to the kind of the beginning, as you mentioned, I'll mention a number of times. This story began in 2012, 2013, when there was a large wave of unaccompanied minors that came in large caravans back then. You know, you're hearing a lot in the news now about caravans and how there's many coming of migrants from especially Central American countries. But these caravans have been going on for a long time. They're not something new. And in particular, in the years between 2012 and 2014, we had a large wave of unaccompanied minors. There's many reasons and why that specifically happened during that period of time, which I won't get into. That's a whole other presentation. But during that time, we had about 65 to 90,000 unaccompanied migrants coming to the United States. I'm sorry, unaccompanied children coming to the United States during that time. These are children who arrived at the U.S. borders without a caregiver by themselves. So anyone under the age of 18 who arrives at U.S. borders without a parent, a caregiver, a relative, some type of guardian is considered an unaccompanied minor. At that time, San Francisco Unified School District was having 500 youth entering each year. Most of these were unaccompanied minors at the time. That's a large percentage of youth when you consider, San Francisco Unified. It's a large school district, but it's not that large. 500 kids, it's a lot of kids per year to come in. And in the Bay Area, as the most recent figures I can get are from 2015, there's thought to be estimated about 1,800 unaccompanied minors reside in the Bay Area as of 2015. Then to flash to now, to 2018, and I'll also put a caveat or, with a note out there that a lot of these figures are really tough to get. You kind of got to scrap these from a couple of different areas, whether it's Office of Refugee Resettlement databases, whether it's immigration courts in the Ninth Circuit. I take a lot of data from them, and with the school district. And it's, not to go off on a side, but it's another project. I mean, epidemiological data, just even demographic data on this population is hard to get, and there's much needed, and it's some of the work that we're also trying to do is to understand more what this looks like on the ground. We all know there's a lot of work and a lot of this is needed, but we don't know the exact numbers. But right now, as of 2018, there's about 180 unaccompanied minors that were released within San Francisco City, meaning that 180 kids were released to families within San Francisco, the city of San Francisco. And this is not accounting for any youth that may have come here with their family during that year. It is not accounting for youth who have not gone through immigration proceedings at all, somehow slipped through the borders or came on a plane or whatnot, and there's no record of them going through immigration proceedings. So on record, there's 180 kids just in 2018. We're expecting these numbers to rise again. And then just going through immigration proceedings right now, this is adults and youth, we have over 3,700 in the county. So there's 3,700 immigrants in the county experiencing immigration proceedings. So they have actual active immigration immigration proceedings in the Ninth Circuit Court here in San Francisco County. And then finally, you're gonna hear me talk a lot about the Northern Triangle, Latinx, Newcomer Immigrant, etc. A lot of the information I'm gonna provide can be generalized to a lot of groups of Newcomer Immigrant youth. I'm gonna specifically focus on folks from the Northern Triangle. This is the countries of Guatemala, El Salvador, and Honduras that are referred to as the Northern Triangle. Because this is what we see in our clinics. This is what led to the beginnings of Fuerte in our pediatric primary care and our child and adolescent services clinic. This is the largest number we're seeing in the county that folks are experiencing a lot of behavioral health concerns with. And it's the one more salient here, but this could apply to a lot of other newcomer immigrant youth. But I'm going to focus mostly on these because these are the ones that are most salient for us on the ground here. I also do want to mention as well that Nicaragua, it might become also another destination or another country from where these youth might be coming from. There's a lot of political instability in Nicaragua right now, and economic instability that may lead in the next couple of years also to a large wave of immigrants and migrants coming from that area. So this is an area that's been historically, politically unstable, has had a lot of wars, gang violence, economic issues, and has been a large push to have migrants come to the U.S. So as you can imagine, these kids are coming in with a lot of behavioral health concerns. There's a significant, prevalence of trauma and violence exposure, both pre-migration, so a lot of these kids are fleeing violence, whether it's violence in the communities, gang violence, whether it's war, whether it's interpersonal violence in the homes. They're also experiencing violence en route. You're hearing again about the caravans on the news, and a pretty significant reason why these large caravans form is for safety reasons. There's folks who come in small groups are more likely to be targeted for assault. So a lot of our youth come in and have experienced violent assaults on their way here, have witnessed murders, have been sexually assaulted, etc. And then many of them also experience trauma post-migration. They get here and they may be exposed to community violence where they're residing. They may also enter into other or they may experience further interpersonal violence in the homes that they're residing in here, etc. Many of these youth are also trafficked, both for sexual trafficking reasons and labor trafficking reasons, which adds a whole host of other concerns. And specifically to kids from the Northern Triangle countries, I want to point out this figure from the United Nations High Commissioner that 60% of these youth would qualify for international protective status, just based on the conditions of these countries and the things that they experience. And that's not a number to take lightly, 60%. Right now, barely any percentage the U.S. recognizes as needing international protection. So, and I want to point that out less so to get into the whole political climate about this, but more so to say these are kids with high risk, at high risk for behavioral health concerns, with a lot of issues that they've experienced that can result in a lot of mental health concerns. And typically what we're seeing with these kids are incidents of post-traumatic stress disorder, depression, anxiety, and increased risk-taking behavior. So both sexual risk-taking and substance use, as well as gang involvement. So it's not unheard of that kids escape gangs to then be involved in gangs here as well. And the reason for being involved in gangs is not necessarily because they want to, but because they have to. Gangs follow them here. So these are concerns that are happening even within San Francisco County. So again, stressing this is a high-risk population and one that experiences significant disparity. So again, kids are in much need of behavioral health services, but this population, compared to the U.S.-born population, is less likely to seek services, less likely to use them, and when they are using services that are less quality. Most likely not going to be evidence-based treatments or anything of that kind. Even when you compare newcomer immigrant Latinx youth to U.S.-born Latinx youth, you'll find that they have greater disparities in treatment access, even within groups. So there's a confluence of causes for this: extreme poverty, language. I mean, a lot of folks will assume the Spanish language and needing Spanish providers, but that's not always necessarily the case. A lot of these folks speak indigenous languages and dialects, and we don't really have translators here in the county or anywhere else that can provide translation for these indigenous dialects. Spanish may not be their first language, and they may not speak Spanish well. So that's a huge barrier that we're seeing here at the county. Undocumented status, although in San Francisco County that's not so much of a concern. All kids have access to health services and mental health services here. Low mental health literacy. A lot of these kids just do not know what mental health is. They don't understand what depression, trauma, what are mental health services, what's therapy, what do they need to do to seek out services. They also feel very isolated. These are fairly recent arrivals of immigrants. And I think folks will say, well, there's a large Guatemalan population in San Francisco, there's a large Honduran, Salvadorian, et cetera. The issue is that we're thinking about it as a country, but these folks are coming from different parts of these countries and other waves. And in particularly the indigenous folks who are speaking these languages and these dialects, that they may not even be able to communicate with the immigrants population that are already here. There's a lot of social isolation with these groups as well. But there's a lot of strengths here and a lot of strengths to harness. So there's a strong family values, and family broadly defined and can also be defined family and community. There's this sense of wanting to have strong bonds with others that need to be strengthened and a lot of emphasis placed on that within these communities. And also cultural values, traditions, rituals that these youth bring in, that these immigrant groups bring in are important to harness. And they've been found to be strong resiliency factors for these populations. And making sure that they don't lose this it would help greatly reduce their risk for mental health concerns. And so, as I mentioned, the story of Fuerte first begins back in 2013. When I was a pre-doctoral intern, and the two postdoctoral fellows I mentioned before, Drs. Marisol Romero and Ryan Matlow, what we were seeing in the Child Adolescent Services Clinic, and subsequently also in the primary care clinic, which we are co-located with at San Francisco General on the 6th floor of the main old hospital building, Building 5, is that we started seeing a lot of these unaccompanied minors coming in. A lot of kids between the ages of about 11, 12, and 17, 18 that were coming into the clinics. A lot of them were coming in for health concerns, for communicable diseases that they were having, for various problems that they encountered en route to the United States at the time, that then were getting referred to us, and we really didn't know what to do. They didn't have formal caregivers, many of them. Many of them were meeting the people they were living with for the first time. And a lot of them had just gotten here literally. Like, we would see a kid maybe 5 days after they arrived in the U.S. So what Drs. Romero and Matlow put together was these family reunification resiliency multifamily groups. So what the purpose of these groups were to kind of establish communication between these kids and these caregivers that they now were residing with, and also to work on the trauma. These were groups that we did at CAS, at Child and Adolescent Services, and they were in multifamily form. So we did it with the kids and whoever they were identifying as a caregiver. Sometimes we meet together, sometimes separate, and they set out this whole program based on it. And it was evidence-based or evidence-informed using the ART frameworks, attachment, resiliency, competency framework, and then also cognitive behavioral components of it. So this program was developed, ran a few groups. I had the privilege of piloting some of these groups with them during that time, and our time ended at UCSF, or folks moved on to the different positions in about 2014, 2015. And then during that year in 2014, 2015, kids kept coming. Primary care, the Children's Health Center, kept receiving a lot of these unaccompanied minors. The county was starting to see a lot of them go out into the community-based clinics and the civil service clinics. So a group a group was put together at the county called the Unaccompanied Minors Work Group. Max Roca, who's now the acting director for Children, Youth, and Families, led this group. And folks started to come together. And in this group also were some of the pediatric residents that I mentioned earlier, Doctors Peter Cooch, Haimanu, and Holly Vo. And they knew about these resiliency groups, these multifamily groups. But what they wanted was, how can we take this and actually use this program and disseminate it more widely in a way that makes sense? And the schools started to make sense, right? There's a lot of evidence in the literature, both theoretical and actual data, indicating why these schools might be the front line. School-based programs might be the front line for reducing disparities, not just among these groups, but a lot of different underserved groups. So they began working then on adapting these family groups into these school-based prevention. They essentially removed the family component, shortened it, made it more flexible, and manualized it. We had kind of like a format. This is a pilot, but they formalized it, created a training, et cetera. And I'll talk a little bit more about the details of that. But first, I wanted to talk about what was the impetus for this, right? Why school-based programs? So they allow for early identification. We can screen a lot of kids at once and target them for any concerns a lot quicker in the schools versus waiting for them to come in even to the primary care clinic. Newcomer immigrant youth almost for sure are going to enter the school district before they're going to come into the primary care clinics. I was talking about this with a pediatrician in the clinic yesterday, how we don't have good data how long it takes them to come into primary care for the first time, as I mentioned, but what we're thinking is, unless there's some critical need, it probably takes a year before they come into primary care. And then that's usually where they get identified for behavioral health concerns, and then probably take another 3 to 6 months after that before they actually get into treatment. So we're seeing a year and a half potentially pass for these kids that are high risk that they haven't even been screened yet. So schools allow for that kind of early screening. We can screen a lot of them coming in. They facilitate linkages. Schools have wellness centers and social workers, et cetera, system navigators that can facilitate linking them to appropriate providers. There's a lot of evidence in the literature that school participation is also associated with increased resiliency, not just for these kids, but just any child, right? And then another thing which some people may find negative, but I think for us is especially important and has been instrumental in development of Fuerte, is that schools allow for local development and smaller scale kind of dissemination of programming. So, you can make these kind of small tweaks and adaptations. Each school is its own ecosystem. So you have to figure out, how do you develop a program that can be easily tweaked but kind of still keep the mechanisms that make that program work. And schools are like a perfect place to do that. So let's provide some of the most recent literature we have. So there's 2 systematic reviews that were done fairly recently, just on looking at school-based prevention programming, intervention programming for newcomer immigrant youth across globally, right? And what they found was the majority of this work has been done outside the U.S., mostly in Canada and Europe. In the U.S., we've had about 5 programs that there's been some studies out there on. However, even within the 5 that we have that were done in the U.S., most were of poor quality, whether the study design used to test the program was of poor quality or the treatment itself was considered poor quality because there was no theoretical basis for that treatment, or it wasn't based on any kind of evidence-informed models or anything like that. In addition, the majority of the work has been done on refugee populations, and I want to make that distinction. So refugee populations are folks that are classified through the Office of Refugee Resettlement, right? And folks who have that classification have access to more resources, more likely to be connected to services than folks who do not have refugee status. And immigrant youth from Northern Triangle countries almost never get refugee status. So that international protective status would give them refugee status, and they don't, and most of them do not. There's that's a whole other conversation. There's some visas that many qualify for. There's temporary protective status, et cetera. But these things are not considered refugee status. It's not the same. So only one of these 5 studies in the U.S. were done on Latinx immigrant youth. And even that study was specifically focused on youth who were screened for post-traumatic stress disorder, and it was an intervention for post-traumatic stress disorder that was done in schools in Los Angeles County. Most focused on depression, anxiety, and trauma. And even then, the effect sizes, based on everything I said, for the studies that could be calculated, so some of them had very poor study design and effects couldn't be appropriately calculated. We still saw small to large effects for these studies. So there's promising evidence also in the literature of the impact that these school-based programs could have. And so getting back to Fuerte, I want to stress that the Fuerte program, so when the pediatric residents now brought this program out into the schools and adapted it for the schools, it was an entirely grassroots effort. There was almost no funding for this. There's been small grants that help fund some of the materials for food, for kind of supplies, creation of the manuals, etc. But that's it. The majority of the folks who were providing these groups are in-kind providers, like clinic directors in the county, including our clinic, Child Health Services, provide a clinician who can do maybe one group a semester, essentially for free. The county is essentially putting resources that they do not have, like their time, to help coordinate this as well and develop the relationships. So all of this is happening unfunded since about 2014, 2015. And even still, this program was able to be disseminated across 9 San Francisco Unified middle and high schools and serve over 150 youth. And even still, without any much of funding for this, there was these residents were able to collect pilot data. They were able to collect some evidence that this program was working, that it's feasible. As you can see, feasibility, just being able to connect to 9 schools. And for folks who've worked in schools, that's just alone is difficult. And to serve 150 youth. And I'll say this is great because it's grassroots, but I'll say it's not that great because I originally told you there was just 180 kids last year came in. So this is not even reaching that just last year, that were coming in. So, and those are underestimates. Those are only the 180 that the school tracked. The school is grossly underestimating the amount of kids that are coming in. So, and another important factor that we gathered from the pilot data with the focus groups and semi-structured interviews that were done with the youth and with the parents as well, the caregivers, was what they were reporting they liked most about the groups was that it increased their social connectiveness. They were reporting they were making friends from these groups time and time again, that it was helping them meet people who had similar experiences to them and start to make social relationships. And that's really what they found to be the most important thing they got out of the groups. And this is an important construct that'll come up later, for us as I talk about our trial. And as I mentioned, no systematic program evaluation has taken place of this, or has taken place right now of Fuerte, just this kind of preliminary data showing some of the feasibility of it. Just to give you sort of an overview as well of Fuerte, it's considered a collaborative shared initiative. Fuerte was developed in collaboration with folks, San Francisco Department of Public Health, Department of Pediatrics here at UCSF, Department of Psychiatry, San Francisco Unified, the youth caregivers is a participatory model. It's considered innovative. You want to say, are school-based programs innovative? I just tell you there's 5 in the literature, right? And only 1 with Latinx immigrant youth, and it was an intervention. It wasn't a prevention program. It wasn't about early identification and detection. So we do consider it innovative, and I'll stress that because I'll tell you why we got our money. So, the groups are led by trained mental health providers. I mentioned a lot of these are in-kind folks from various clinics as trainees in the various clinics, social work, psychology trainees, marriage and family therapists, and also includes school staff, and this is important. So the group is ran by somebody who's both the school representative as well as a mental health provider. And I think that's important as well to build that connection both at the systems level and as well within the kids. Targets youth ages 12 to 18, and it's evidence and trauma-informed, as I mentioned, using the ARC framework and cognitive behavioral components. I don't want to go into too much detail about the content of Fuerte, but wanted to sort of give you an overview of what the modules are. So, again, the importance of Fuerte is flexibility. It's meant that these modules need to be covered, and there's, points that essentially you need to cover within each module, but how you do it is completely up to you. And the importance for this is that we don't even know sometimes how much time we have to do the group until the day we get there for various reasons. And some schools will let you have a class period, but a class period could be 40 to 50 minutes. Other schools will give you an hour and a half. The group was initially designed to be an hour and a half and done over 6 to 7 weeks, so it's relatively brief, right? But as I mentioned, if some of the schools are only allowing you 40 to 50 minutes, this could stretch out to 3 to 4 months, and which still would be considered relatively brief in the grand scheme of things. So the model is flexible, so you can do it in as little as 6 to 7 weeks or over a span of 3 to 4 months. And the first module is just an intro to the whole program, the goals of the group. Second, as I mentioned, culture, routines, rituals, traditions, these are important. So it's important for the kids to discuss this, not only their own from their home countries and bring it to the group, but to also start establishing routines, rituals, and traditions for the group itself. The third is affect identification. Again, this is the mental health literacy component. These kids don't really understand what feelings, what depression is, what anxiety is, what's trauma, etc. And this is where we begin to help them identify that. And the fourth is learning basic coping skills. So we use mindfulness, distraction, cognitive behavioral kind of evidence-based evidence-informed coping skills. Fifth module is the stress of immigration module. We don't do a formal kind of trauma-focused exposure like you would find. This is not the goal of this. If kids want to bring up traumas that they experience, we allow for it in this session, but it's not something that we purposely elicit. Sometimes it does come out. What we talk about is stress and trauma generally and what folks may experience, so they understand that this is something that might be common between them, and also not only the stress of what they've experienced, but what they might be experiencing here now, whether that's discrimination, racism we cover, whether that's acculturative stress, so stress of acculturating to a new culture, the U.S. These are all things we cover so that they have an understanding of it. The sixth module, we look at attunement communication skills. A lot of these kids, like I mentioned, may be reuniting with caregivers or meeting different caregivers they've never met before in the U.S. and really just need basic communication skills to kind of express their needs to them. And the final is the conclusion, usually celebratory, usually involves food. So what does San Francisco County then need? So I mentioned we don't really have a systematic program evaluation of Fuerte. There isn't much evidence available out there of any program. I mean, we've done informal kind of reaching out to folks across the country to see if there's programs out there. There's a few kind of prevention programs here and there, Virginia, Chicago, sort of LA, but nothing that really was based on evidence, and nothing that really has been disseminated as widely as Fuerte. So Fuerte is essentially, the program that we thought was a good for trying to bring this in and scaling it up at the county. We don't really have much of an understanding of prevention programming for this youth. There is none at the county. The primary care clinics have some, but again, as I said, it could be a year potentially till these kids come there. So we wanted to do something where we can do early identification and linkage within the schools. And hopefully, with collaborative relationships in the schools, we can do that as soon as they enter the district, right? And programs that are culturally responsive, trauma-informed, community engaged. And so this leads me to then how I've come back in the picture with this. So we have Fuerte, that's been since 2014, 2015, running on essentially no funding and grassroots efforts led by these pediatric residents. Now these pediatric residents some of them have moved on to other positions, they're now fellows, et cetera, or about to move on. And how are we going to sustain this program? So when I started as faculty about 2 years ago, various folks who are involved in this approached me about wanting to figure out a way to sustain Fuerte over time and figure out funding for it. And one obvious thing was, well, in order to get funding for this, we need to test to see if it works. So let's try to go that route and first try to find funding to do a proper systematic evaluation of this program. And so about a year ago, the county then approached myself and the other collaborators here at UCSF about coming into partnership with them, San Francisco Unified School District, around a Mental Health Services Act grant. And what the Mental Health Services Act is, for folks who may not know, this is also what's commonly known as the millionaire's tax here in California, is that 1% of all salaries, $1 million and higher, 1% of that amount goes into this fund that helps fund mental health programming across the state of California. This is on any program that might not be covered by Medi-Cal. So a lot of it is around prevention, early identification, etc. And one of these grants that they fund is this Innovations Grant. And this is for programs that have high potential to be disseminated throughout the state and that can be found to be effective in targeting high-risk populations, usually underserved populations. So the commission, the Mental Health Services Oversight and Accountability Commission, is kind of the commission at the state level that oversees this funding. And we submitted a proposal to them, they accepted it, and we went in front of the commission. Then the requirement is you go in front of the commission and now have to defend your proposal, and they vote on it, which we did in January, and they funded the county then for this proposal. So the county now has $1.5 million over the next 5 years to fund Fuerte, and that's what I'll be talking about in a second, is what is this going to fund. So we proposed 3 innovations. The first is an evaluation of the Fuerte program in general. We're going to do a randomized control trial, which I'll give you more details in a second, looking at its efficacy. Second is adapting it. We want to create playbooks. As I mentioned, when I went back to why schools are such great places for dissemination, because you can look at these local adaptations and before you go to scale, right? So before we go to scale with this, what we can do is start to understand, well, how are clinicians adapting this locally and keeping the mechanisms of Fuerte in place? And then we can create frameworks of this, and we have various frameworks in the literature, which I'll talk about in more detail a little bit later, to do this. And then finally, there's no way that Fuerte would have been disseminated in 9 schools, served 150 youth with 0 money, without the systems that were in place, the cross-sector collaborations. So what exactly is needed at the county level for this to happen? And that's the second playbook that we want to do, not a playbook for clinicians to use or for folks to think about adaptation, but for the counties to have. And so it's an organizational framework. We want to hit every level, right? So we're hitting the efficacy level, then we have the larger kind of adaptation, and then finally what's the implementation science around the organizational frameworks involved in this. And the specific study aims are conduct this randomized trial. We're aiming for at least 8 San Francisco Unified schools, serving at least 400 youth, 100 per year over 4 years. Develop a provider playbook that will inform the adaptation of Fuerte, and then create this framework for interagency partnership. And so for the first aim, the randomized trial, we're going to use a cluster randomized delayed waitlist control design. All youth, what we're defining as Newcomer Immigrant youth is any youth that has come into the United States within 5 years. And we're targeting Latinx youth between ages 12 and 18. At least 100 participants per year in at least 8 San Francisco Unified Middle and High Schools. So a parallel analysis indicates we'll have more than enough kids for this. The problem is going to be the clusters, the schools, how many are involved. We're going to need 12. And I say at least 8 because 8 are the number of schools we got that we know for sure we'll get in. We're pretty confident we can get 4 more. It's just that it's for the purposes of this, we only were able to get buy-in from 8. And I say only it's, I shouldn't say that, because school district is. We got 8, yeah. But we should have enough, and essentially we're pretty confident, at least by year 2, that we could maybe convince. I think some schools will be, there's early adopters and the ones who are going to wait and see what happens, and once they see that this is rolling out, then maybe we'll get some more who might be interested. And so some of the outcomes we're looking at for the RCT include screening and referral. So we're using pediatric symptom checklists. One, because it's free, it's easy to use, it's quick. And second, because it's been validated with this actual population with newcomer immigrant youth from Latin American countries, specifically from Central American countries. And we have norms, cutoff scores for that population. Also, referral, so just do they get connected to a mental health provider is another measure that we're using. Yes, it's just yes or no. We also want to measure social connectedness. I mentioned the kids thought this, or kept mentioning this is an important construct for them. So I want to measure it in two ways. One, subjectively, so how are the kids perceiving that they're connected to other kids? And then an objective measure, which is taken from the Los Angeles Family and Neighborhood Survey, which was done in LA County a couple years ago. This is an objective measure, just items that ask how many friends do you have in the neighborhood, how many friends do you have in school, etc. And finally, we're going to create a mental health literacy measure specific for this study, but that will be based on the mental health literacy literature, where we're going to have 3 items that look at the kids' knowledge of trauma-related symptoms and mental health symptoms in general, 3 items that measure their knowledge of the mental health system, and then coping mechanisms they learn. So essentially, all the content of the program is, did they learn this content? And this will be the measure of that. So our second aim are the adaptations. So we're going to use qualitative approaches for this, semi-structured interviews with everyone involved currently and who will be involved. We're going to use Barrera's cultural adaptation frameworks to develop the questions for these interviews and to analyze and code the data. We want to understand what is happening, locally with these adaptations, and then what we're also going to do is something that I haven't mentioned up until now is part of our impetus is also to adapt this to other groups, particularly Chinese immigrants and Arabic speaking, because the county and San Francisco Unified is reporting these are 2 groups that would benefit from this as well. And so we want to get both data on how folks have done this, and then data from folks who, what would they need from this program. And this way we will use a lot of the theoretical literature around cultural adaptations to then develop a framework for doing this. And then the third aim is the organizational collaborative framework that I mentioned previously. This is going to use frameworks from the implementation science literature, mainly Gregory Aaron's EPICS framework on implementation and dissemination, and the collective impact model, which is an implementation science framework for cross-level sector collaborations that was developed at Stanford. And these 2 frameworks will develop the questions for the semi-structured interviews. We're going to talk to everyone who's been involved with Fuerte, essentially from the beginning, to create this so that then when we go in year 5, the goal is to start to have this done and then talk. And there's already, as you can imagine, you can guess which counties already contacted us and are saying they want to be the first. They probably should be. I mean, they're the ones with the largest immigrant populations, but this will help them then decide, or not decide, but know what they need in place to do this properly. Because it's not just about taking Fuerte and just doing it in a school. You're going to need to have all these players kind of in place, right? So then in conclusion, what to leave here with today. So I talked about a lot of concerns with this newcomer immigrant population, right? And I don't want it to be all negative. I think there's a lot of positivity here. There's a lot of positivity within this group. There's a lot of strength and resiliency that we really need to harness. And we have solutions in place that are fairly, fairly easy to implement and cost effective. Including these school-based interventions. I keep stressing the importance of community engagement and cross-sector collaborations and community participatory models, and then as well as stressing the importance of theoretical frameworks, right? It's not just important to know why things are done, but place this within the context of theory that we have, particularly implementation science theory. So these are 3 solutions that we're finding that will help start to solve this disparities problem within these newcomer immigrant youth. And with that, I want to thank, again, all my collaborators. I'm privileged to be working here with all of them on this project. I especially want to thank, again, the youth and families. This work wouldn't exist without them. They've put in a lot of time, and we, again, no money, so it's not like we paid them to do this. Maybe we'd have some food here and there. They gave a lot of their time to develop a lot of the materials for this. And just in informal and formal ways. So I want to thank all of them, and I want to thank you all for being here, and I'll take some questions now. Yes.
Congratulations, first of all, on the award. That's a huge accomplishment. We had a talk a few weeks ago by someone who sort of gave an overview of some of the health risks, the mental health risks for migrant laborers from Central America, specifically they're at risk for STDs, HIV, alcohol, and I just wonder about your population, whether or not there's an opportunity to collect some risk behavior associated metrics such as that, exposure to violence, alcohol use, etc.
I should repeat the question. Yeah. Okay. So the question was whether there's, I'll just summarize it. I know you asked. If there's any potential within this project, the Fuerte trial, to collect data on risk outcomes like substance use, violence risk, et cetera. Right? And yeah, there is. That's actually, this is what we proposed to the state, but we're looking to get a lot of that information. We have and by qualitative I mean anecdotal data, that there's a lot of these youth that came back in 2012 to 2014, that there's a number of them that are now in the homeless shelters, a number of them that are addicted to various drugs. I think methamphetamine's a big one. A lot of them that kind of wound back where they started, in the sense of ones that were escaping like gang violence that now got picked up here, or are now being trafficked for selling drugs, for labor traffic, for sexual traffic or sex trafficking. But it's something we're hearing anecdotally coming out of the homeless shelters and various community-based organizations. It'd be great if we were able to get some of that data of kids coming in now that we can track over time as well. But tracking this population is always very difficult for a number of reasons. One, economic instability here in San Francisco. You know, a lot of folks will be here for a bit, but a lot of them then leave because it just becomes unaffordable. A lot of folks are also residing, many people in one place. So issues of crowding in their housing are significant for this population here. And that's actually another risk factor, which also with the migrant agricultural workers is a risk factor for a lot of things, is housing crowding, which is another one we plan on collect as well.
Great talk.
Thank you.
It's really exciting. I'm interested in a specific engagement. Obviously, there's a lot of reasons where, especially in the current climate, where people, it might be hard to track people. But I'm also interested in just kind of the traditional reasons, like in a high school setting, why it seems like many of these kids may or may not want to be involved in one of these groups. And so I'm just curious in how you kind of set that up and deal with stigma and internalized oppression and all of those kinds of things to get kids to come in the first place so they can take advantage of this.
Okay. So the question is, how were we able to engage kids to participate in these groups when there might be a lot of stigma and just generally around mental health, but also for this specific population, for reaching out for some of them perhaps who don't have documentation status, and what this means. I think that's a great question. I think that goes back to our kind of cross-sector collaborations. If we didn't have these folks at the schools involved that already had these relationships with a lot of these kids, and with a lot of that population, I don't think we would get a lot of kids to come in. Another thing but what we do find is that this varies by school. Some schools are much better at getting their kids to come in to participate than others. Right now, really the way it's been ran is, here's this contact at the school, the social worker usually. Do you have any kids that would participate in this group? And they send you 8 or 9 kids, and maybe 5 or 6 of them stay, right? What we hope to do is figure out a way with the district to make it part of their curriculum, so their health curriculum, so that every newcomer kid that comes in gets this curriculum at some point within, the first couple of years that they're here. I've heard it being used. There's folks at San Francisco State that have been able to incorporate stuff in the health curriculum around sexual risk-taking, around substance use, et cetera. And I'm trying to figure out ways to do that, but that's easier said than done. That's changing the curricula, which is like...
Right, and then you've got to have health teachers, which are providing it.
That becomes... Exactly. And that changes what we're doing, So, and then you might find unintended, perhaps negative consequences of your outcomes because it's not anymore what it used to be, right? So it's getting more kids in versus doing what we've set out to do, and we're trying to balance those two. Yes, Dr. Stewart.
So thank you. Wonderful talk. Really fantastic, and needs Christine efforts at getting funding for this. It's been running on fumes. It's amazing all the effort that's gone into it, and no one's gotten paid for it. So really, really amazing. With that said, my question is around the adopt and adapt question. My holy grail question around dissemination and implementation of evidence-based treatment. So I was wondering if we could talk a little bit about what do you mean by you're giving flexibility and leeway to clinicians and settings to adopt and adapt. And I'm wondering what adapt really means. Like, it's a principle-based approach, and so as the field moves towards that, there's a lot of creativity that still retains fidelity to a model. So I'm wondering what you mean by adapt.
There's a lot in there. Okay, let me see if I unpack that one. So Dr. Stewart's question is, what do I mean by adapt? So I think that's an excellent point, and I think it's a point we're still trying to sort out by these frameworks before we decide to look at this. So there's the issue of fidelity, right? And I didn't really talk about that, but we're going to have measures of fidelity as well. But what is fidelity in the context of what we're trying? This is not an intervention, right? Yes, they're learning things, but we're not trying to intervene on a mental health disorder in a formal type of way. What we're really trying to do is provide information. It's a lot of psychoed. So we're less concerned about fidelity for those things. I know I'll answer the adapt thing around that. What we're more concerned is, do you teach them all the constructs in this particular module? So if you're teaching them 3 coping mechanisms, it doesn't matter what 3 you teach them in this module, right? But it does matter that they are evidence-informed, however. So there's a list, because folks may find as groups move on that certain things stick better with that group than others. Then there's the idea of adaptation, right? This is a long-standing debate in the field that no one's figured out. And why I want to have this playbook is because I think I'm hoping to answer that question through this to some degree. There's a lot of theoretical models out there, but there's no practical models. Like, there's no practical way, kind of frameworks for what do I do as a clinician now to adapt this treatment? Like, what steps can I take to think about this? There's theoretical steps, and then how we can measure if that works. But that's totally on this research kind of academic level. But on a day-to-day, what are the most appropriate steps that we can take to adapt this treatment without losing the integrity or the mechanisms that make this treatment work, right? That's what we want to find out. If folks are doing all that's possible to do that, how do they make decisions about that? So, that in and of itself could be a larger scale project. It's like just decision-making around adaptations. We don't want to go that far. We want to just kind of have an idea so that when folks in the future want to then disseminate this out to other groups, they know what to think about. So what do I need to think about not only in a day-to-day, in module 6, like, hey, this module, or not 6, 5, which is the stress of immigration. So when you're working with folks, if I'm going to be working with Arabic-speaking population from Syria, what do I need to consider? Because that might be a lot more different. Could be a lot more different how you talk about that, because it's specific, very recent wars, than kids that may be exposed, that may not be exposed, and you have to take considerations in what you cover, perhaps, right? So that's what I'm referring as, like, kind of globally for adaptation. That's at the kind of at the ground level. But then there's ideas of, like, there's schools that may say, I don't want you talking about stress with these kids or trauma, because now I got to deal with these kids for the rest of the day. So do I have to take this module out? Did I adapt that? So, and those are more systems. Those are the two things that we're kind of want to look at. Is that happen? I don't know if that's happening, but I've heard that it happened with one group. But I don't know if that's happening consistently. So, any other? Yes?
I want to join the choir of admiration and gratitude of people like you and your colleagues have been doing. This is a tremendous effort. And as I've been thinking about it, I've wondered about, is there support built in for those that are actually running these modules? Because it seems to me that they're going to be without a ton of distress. And I wonder if there's some line in there around, talking with them, getting their information as they go, but also really providing them support as they're doing this work.
So just as for the providers, right?
Yeah.
So the question is, is there any mechanisms in place to provide support? I'm assuming you're like around vicarious kind of traumatization and whatnot for the groups. Currently, there is no formal. I mean, there's sort of informal. These groups, all these folks are in some type of agency, but I think that's a great idea. That's one that we've been talking about. How do we create a formal kind of group, even just around this, for providers to?
Like consultation?
Yeah.
Something like that.
There isn't, just because there hasn't been any formal funding, and folks are already putting in so much time just doing it, that finding that. But informally, people do connect with each other around this. So, but that's a great idea, and one that.
Could help with burnout too.
Right. Thank you. What do we got? Probably take one last. Yes, in the back. Yeah, so that would be the whole purpose. So part of what we're looking at is can we connect these kids to specialty the kids who need it, who get screened for the So essentially we have two groups that we're looking at here. We have a group that we think is at risk, but maybe we teach them some coping skills and they learn a little bit about mental health, and maybe they'll just kind of, that risk will be mitigated and they won't need specialty mental health, right? Then we got another group that's going to be screened for specialty mental health that will teach them all this as kind of a preparation and linkage to specialty mental health. And so the whole goal would then be to link them. Now, what we're trying to figure out is how that linkage happens. Now it's just not really done in any type of structured way. Could be the social worker at the school, could be the provider in that group links them to the clinic that they're in, could be through the wellness center, through a primary care provider in the school. We're debating whether to formalize that process and have an actual system navigator that's part of the group. But then what are you measuring? Are you, if the group works, is it because you have the system navigator, or is it because of the program, right? So we want to first test the program, so that's kind of the tension that we're doing with that. Any other questions?